Okay, good afternoon, evening, everyone. I can see as folks are starting to trickle into the webinar. Welcome, welcome, welcome all. We are on our 8th selection for the Health Equity Book Club. Here we are now in December of 2022, a time that felt like such far in the future, and now it is here. But I'm glad you're all here with us as we get along. Just to kick things off, my name is Danny. I'm the program coordinator for the Office of Cancer Research Training and Education at Karmanos Cancer Institute. If you need to get a hold of me or find out more about the book club as we get along, book selections, you want to read and look at past selections, we've got all of our pre-recorded sections are all there at karmanos.org/book club. And so everything goes there. We also have our mailing list. And if you want to get on our mailing list to get, well, if you're showing up here, you're on our mailing list because I pull it from the registrations. But if you want to share it and spread the word, people can access getting on our mailing list at karmanos.org/book club there too. I've got a form you can fill out real easy, and then you'll be included. So I also want to give a hearty hello to Monique Green Jones's MPH 2500 class, the Race and Ethnic Disparities in Public Health course. I'm sure you all were invited. I'm glad you're here. I don't know what I'm saying, but I'm glad you're here. Welcome, welcome, welcome. We are going to have a great conversation today. We are discussing, and I'm probably mirrored so you can't read it, but why are health equities, health disparities, everybody's problem by Dr. Lisa Cooper. And so we've got some wonderful panelists for us today. As a brief sort of program note, Jason from Michigan Department of Health and Human Services wasn't able to join us today. And we are also waiting on one other panelist to sign on to join us. So far we have two excellent panelists that are on the top of everyone's mind when they're thinking about health disparity at Wayne State and KCI. So I want to then give a little nod to our future book club, so you can mark your calendars. Our next book club will be Thursday, March 30th. If that date changes, for whatever reason, if we're discovering something's going on, I'll send an email through our mailing list and we'll post it on our website, again, karmanos.org/book club. But that will be Thursday, March 30th at 4 o'clock, right here, same as we've always done. So with all that, thank you all for being here. Welcome to December. I want to turn it over to Dr. Simon, who is going to moderate the rest of our evening. Thank you so much, all.
Great. Thank you so much, Danny, and welcome to everybody. It's really my pleasure to welcome you to this Karmanos Cancer Institute Health Disparities Book Club. I am a medical oncologist. I am the co-leader for the breast multidisciplinary team, and another little title I carry is the medical director for cancer genetics. Believe it or not, as Danny said, this is the 8th book that we're reading and discussing. And we've also read one research paper that came out of our group. I believe that the success of the book club has been due to the support of Karmanos and our affiliated institutions, including McLaren, Wayne State University, the Detroit Medical Center, as well as the insight and expertise of our now approximately 30 panel members, who over the last couple of years have included patients, community activists, healthcare providers, students, trainees, and university administrators. So really quite a auspicious collection of people that have provided our panel discussion. In reality, the success of the book club is largely due to our participants. We have some 510 individuals who have participated at least once. Of course, some of them may have participated more than once on our email list. So what's new with the book club now in December? On this past Sunday, I had the opportunity to be interviewed along with our community participant, Deborah Tucker, by Angela T. Moore for her radio show Empowered on 910 AM Superstation. A link to our interview will be on our website, or is on our website already. We're also, as Danny said, proud to welcome students from Monique Green Jones's class, PH 500, Race and Ethnic Disparities in Public Health. And we were very happy to provide those students with a copy of the book. I encourage everyone to buy the book if you haven't already, or buy one of the books on our list. this is an excellent holiday gift. So I actually throw in this nice thing. I said, remember, my dear participants, drop everything and read. So I would like to make a few points about the book, because of course, not everybody has had the time to read the book. I'll make those comments first, and then I'll introduce our panelists. We may be down a panelist, and so generally we give each panelist 8-ish minutes, and we could probably expand that a bit. And we'll maybe have a little bit more time for a group discussion. And of course, if we don't have as many panelists, there's nothing wrong with ending a little early, but we do have our full hour. Okay, so what are my takeaways from the book? This book, Why Are Health Disparities Everyone's Problem, by Dr. Lisa Cooper. So one takeaway, Dr. Cooper has a fascinating personal story, having grown up in Liberia as a descendant of slaves, and though part of the privileged class when she grew up. Her father was one of the leading physicians in the country, the head of one of the hospitals, the teaching hospital, and her mother was a head librarian. Both parents were, of course, trained in the US. And she was able to see firsthand through the hard work of her family, the striking divide in society in Liberia. At that point, she was a privileged class. She had the privilege then to follow in her parents' footsteps, and especially in a tumultuous time in Liberia, fleeing revolution and destruction. So she was able to come to this country, and then she found herself looking at inequities in the United States and experiencing racism now as a Black American and some of the same issues that her parents faced. Dr. Cooper has taken on health disparities as her life work and has developed a profound network of collaborators in the US and internationally in order to provide equal access to healthcare for all. Her focus is in the area of depression and hypertension, but I believe it has similar implications to the work that we're doing in the cancer world. Her goal is to make equal healthcare a basic human right. She makes the important point, though, that equality is not the same as equity. She shows a graphic, a nice picture from the Robert Wood Johnson Foundation of people of differing abilities trying to ride a bicycle. Of course, we're all different sizes and ages and abilities. And I quote, as she says, when it comes to expanding opportunities for health, thinking the same approach will work universally is like expecting everyone to be able to ride the same bike. We won't achieve equity by giving everyone the same thing or stating, putting them exactly in the same place, but by giving people the resources that they specifically need for optimal health and well-being. The work of Dr. Cooper and the community work that she is doing reminds me of the work that's being done at the Karmanos Cancer Institute, including by Dr. Haley Thompson, who is one of our panelists in our Office of Cancer Health Equity and Community Engagement, and their outreach into the Detroit community and the development of our 11 Cancer Action Councils. So I'm going to end, and I'm so happy that Rosalind is able to join us. I'll end with a quote from the book by the famous physician, Dr. William Osler, which aptly sums up for me a major point of the book. Is much more important to know what sort of patient has a disease than what sort of disease a patient has. Okay, so I'm going to introduce the panelists. And again, I'm so happy that Rosalind joined us. And Rosalind, I'm going to give you a chance to catch your breath and listen to some of the other panelists. So, approximately 8 or so minutes per panelist. I'm going to start with Haley Thompson, who I can say is a friend of mine. She is a tenured professor in the Department of Oncology at Wayne State University School of Medicine. She has a PhD in clinical psychology from the University of Pittsburgh. She is the 5th Black woman to become a tenured full professor in the medical school's 150-year history in Detroit. Dr. Thompson is also the Associate Center Director of Community Outreach and Engagement and Faculty Supervisor of the Office of Cancer Health Equity and Community Engagement, which I'm sure she'll speak about here at Karmanos. She's the developer of the group-based medical mistrust scale, which has been administered in over 70 health disparity studies. So Haley, please take over.
Oh, hi. Thank you for the kind introduction. Hopefully everybody can hear me okay. I kind of wish I was the last person to go because I'm going to come a little bit from the left on, on this book, but that's okay. You know, we'll circle back around. So, you know, just to talk a little bit about Dr. Cooper, I will say that, you know, she is someone who I've admired for many years now. Her seminal work, or just really kind of, I think, groundbreaking work on patient-provider communication is it's work that has really influenced what I do. I have cited it many, many times. You know, a lot of my focus, as Dr. Simon mentioned, is focused on medical mistrust, specifically group-based or race-based medical mistrust. So it's very much aligned and adjacent. So, and I actually ended up reading this book about a year ago. It took a brief sabbatical to work on a book project. The book's not done yet, hopefully soon, but this has inspired me to kind of return to it. But why I read it for that purpose is because I was thinking about her work and thinking about, you know, who we are and what we bring to the table as researchers, actually. And I really was thinking about how important it is, how our experiences shape our approach to the work that interests us, to our research, to what we study. And I was thinking about Lisa Cooper as a Black woman, and, you know, Dr. Simon shared a little bit about her background growing up in Liberia, growing up with a physician father, kind of, and observing his work. You know, she talked about how in the book, how he would work with people from different backgrounds. He could speak different languages, right? He could work and talk across kind of the class divides as a physician in Liberia in his own work, right? And I thought that's so interesting, right? Because here we have, you know, we have that she's seeing her father being able to communicate and being able to relate to patients across all different backgrounds. And she goes on later in her life to study patient-provider communication. That's not an accident, right? She's taking her personal lived experience and applying that to her science, right? But and I thought about another researcher, Sherman James, right? Sherman James is another behavioral researcher. He's actually an epidemiologist, but he focused on what we call John Henryism. What's John Henryism? It is this model of what we call effortful coping, you know, because he took his own life experiences, you know, growing up African-American in the South and going to a historically Black college. And he talked about the common narrative in the United States that, you know, Black people are lazy, we don't work hard. But what he saw around him, you know, he would interview different farmers and people who did that kind of work in the South as part of some of his early science. And he, you know, he knew that wasn't true, right? These people, not only they're working hard, they're working themselves to death, right? Because they want to create a legacy for their family. They want to create a legacy for generations to come. And he used his lived experience, right, to think about effortful coping. What happens when you're trying to work so hard, but you don't have the resources to get you from A to B, right? That has takes a toll on your health. That takes a toll on your cardiovascular system. And that's why he came up with that concept of John Henryism. So it made me think about, you know, how important it is that we have people who have diverse experiences contributing to our science, right? And it really, to me, I guess I'm thinking about this book and talking to you about it from a DEI perspective, diversity, equity, inclusion perspective. And what Lisa Cooper and this work and her body of work and her legacy shows to me is how important it is that we make sure that we have Black scientists, Latinx scientists, Indigenous scientists at the table, particularly when we are studying those populations, are trying to work with those populations, you know, should be working with versus usually we're doing, you know, researching on versus researching with. But how important it is that we bring scientists of color to the table, you know, and, you know, honestly, we work in a place, you know, certainly we are in the city of Detroit. I'm thinking about Detroit specifically, where it's almost 80% of the population is Black. And, you know, there are many studies who are focusing on Black populations that don't have any necessarily Black scientists in leadership of those or participating in guiding that work. And we really think we need to take a step back and question why that is. What is happening? What is going on there? And that's what kind of part of some of what I'm coming to this book, or what is kind of resonating with me when it comes to this work. And just to read a little bit of this, you know, on page 193, she writes that so many factors combined to target vulnerable groups can be overwhelming. Yet everyone's health is connected, both within communities and across the globe. Inequities and opportunities to live a healthy life also lead to other societal ills, including violence and civil unrest, which can lead to economic and political instability and poorer quality of life for all within a society. I've experienced this on a deeply personal level in Liberia, where I grew up, and now in the United States. And I think, I just hope that we can kind of take texts like these to really think about how are we evaluating the contributions of people of color when it comes to our science. Are we working to make sure that we're including scientists of color in these projects and in these research studies and in leadership of the and making sure that we have there is leadership from those scientists in our work. Because there is value. People have a different perspective, right? We can bring a very unique perspective and really strengthen that science when we kind of, again, add these different perspectives. So that's what I wanted to add. Thanks.
Thank you. Thank you so much. And you will get a chance to comment again later, which is a nice part about our the way we have this set up. So thank you for going first. Okay, so I'm going to introduce Dr. Patricia Yvonne Miranda Hartsuff. And thank you for coming. And she is a health equity policy scholar with over 18 years of experience with community-based participatory methods and expertise in the measurement of population-based health disparities. She has a PhD in health behavior and health education from the University of Michigan. She joined Wayne State in August of 2020 as a tenured associate professor of public health. Dr. Miranda is the founder and director of Wayne State's Hub for Evaluation and Learning, HEAL, Detroit. Additionally, Dr. Miranda serves as vice president and director of Uphold, a nonprofit organization that enables nonprofit and community-based organizations working in youth and community empowerment to recreate and implement measurable programs, and works with community organizations to improve program evaluation, impact assessment, and sustainability. So that's a big mouthful, and I'm sure you could explain it better than I can. Thank you, Tricia.
Thank you, and thank you for the invitation today. So everyone can hear me, right? Okay, thank you for that affirmation, panelists there. You never know in Zoom land. So shout out to our public health students who are on here today that were greeted earlier. Many of the opportunities I'll actually be sharing with you today are open to students, so do feel free to reach out to me if you feel so moved. You will also see that in my sort of planned comments, I circle back to the topics that Haley touched on towards the end. It's almost as though we planned this, but we did not. We actually just met a few minutes ago. So, but I do also love that she mentioned Sherman James as well. He was the chair of my department during the first 3 years of graduate school. Yeah, he was. And he had a huge influence on my career and the career and just, I mean, if you just think about the influence that an individual can have, influence the careers of many of my peers in our department and the work and research that we went forward and continued to do. And his article, The Narrative of John Henry Martin, is one of my favorites to share with students. And in fact, it's on the reading list of my public health capstone students because it is one of the rare published examples of someone telling the story of how they came to their research questions and just sort of the background experiences. And I just think it's just a really lovely example. So thank you, Haley, for bringing his work up as well. So we were given a few prompts for today. My remarks are a little more formal, so you're just going to have to go with it. But one of the points that I wanted to start off talking about is one of the largest natural experiment findings of the COVID-19 pandemic taught us. And so what it did was it repeatedly demonstrated that a concentrated focus, effective funding, and community buy-in can change behaviors and attitudes. And that those are factors that all three actually need to be present to successfully start to tamper health disparities. The inequities still need so much more work, but we need to continue to highlight the focus on community data-driven work. I actually arrived here at Wayne, as Dr. Simon said, in fall of 2020. So it has been a bit of a bumpy ride getting onboarded to the important work addressing these issues that are going on across the university. So in the meantime, I work to build the Hub for Evaluation and Learning, or HEAL Detroit. And I'm thrilled to have this opportunity to share the work of HEAL with all of you, so that if you are interested in some collaboration, please reach out. There's just a lot that needs to be done. HEAL was founded on the principle that to accomplish transformational change, we must build professional competency in our communities. So we're hoping to serve as a nucleus for matching evidence-based solutions and that data-driven work with community-engaged approaches to address social and structural determinants of health disparities through increasing community capacity. So we want to apply a systems change strategy to bring about the structural, relational, and transformative change using a racial equity lens. And ultimately, in doing so, we hope that we're actually going to be shifting power and resources back into local communities. These aren't words that you generally hear traditional academics say. And when I speak to community members, they're generally like, I don't really hear this often. Are you for real? And I'm like, yeah, I'm for real. So I've built up a couple of project partnerships thus far in HEAL. My first couldn't have been more idyllic. I was able to be a partnership with Detroit's Accounting Aid Society. They were funded by the AARP Foundation. We were awarded $200,000 to the partnership to explore pathways to engage underserved senior populations with the Earned Income Tax Credit, the EITC, because increased eligibility of EITC has been linked to reducing income inequality. Receiving EITC has been linked to improved health outcomes. And so we worked together to create a toolkit that included info sheets and social media campaigns that became available in Arabic and English and Spanish to help community-based orgs learn about the benefits of the expanded EITC credit, and where it has a really amazing potential is it's funded by the largest interest group, right? The AARP Foundation, largest interest group that advocates for the interests of people over the age of 50. So there's potential power there to lobby for the permanent expansion of these tax credits. And so being brought into that work, I just thought it was an amazing opportunity for the first go to potentially influence policy change in ways that, because the income tax refund check for some families, that's the largest check that they receive all year. So to potentially increase that opportunity for our families is really great. And then secondly, I've had the opportunity to lead HEAL Detroit as the Detroit community site point of contact for Project Refocus, which is funded by the CDC Foundation. It's a $1.7 million grant that Project Refocus stands for Racial Ethnic Framing of Community-Informed and Unifying Surveillance. That's why it's just Refocus. So we are working to collaboratively collect community feedback for a public health crisis monitoring system that examines risk factors and social exposures relevant to COVID-19 response. It's going to use a dashboard to link data to other public health outcomes. You might think, well, the pandemic is winding down. Why are we still interested in these COVID-19 data collection systems? One issue is, I think the glaring issue is the number of emergency response dollars that came out there that we are still grasping to hold on to. I'll speak more about that in a second, but in this Project Refocus, we're really working to explore opportunities for the expansion or the establishment and expansion of these data collection systems. We are looking to develop a model for communication materials and recs for responding in real time to this data. My community partners, one of the things that they identified from the beginning of this project was it was all well and good that they would announce vaccine sites, etc. But when our community members arrived, there weren't translators that were present. So working to try with these funds to build this basic communication infrastructure within their organizations to maybe also have some more sustainable funds, as then their community orgs can offer translation services themselves, right? And perhaps generate some additional income dollars there. But certainly community partners are saying there weren't people there who could communicate those messages to our communities when they actually did arrive on site. And so that was an important lesson. And in Project Refocus, we're also working to leverage and empower these community-based efforts by providing tools and technical assistance, especially to frontline workers. And then another interesting component is engaging media outlets and ethnic media journalists to help share best practices and help deliver those messages out to our communities with individuals who are already successful in reaching out to our community members. So throughout the pandemic, our most historically racially traumatized communities in Detroit remain largely uninformed and underserved, in part due to those limited availabilities of some of the translators and interpreters and that disseminated information. And so we really see this as an opportunity to not only provide community input, but to build that community capacity and really try to get our communities into a place where they are ready in the future to respond to the next public health crisis, which we know will be there, or they remain there because they never really left our communities. So not only do we need to do community-driven work, we need to maintain the momentum of lessons learned and maintain the focus in the face of transitioning policymakers so that they can continue to make an investment in the tools and resources that have been created, because folks, the health equity work of the past 2 years has been heavily subsidized, and the money chasers have been out there to make a grab for it. And what happens when that money goes away? So sustainability is necessary to build that resilience in our marginalized communities, and that not enough of us come from, which is one of the many parts of the book that resonated with me, along with Haley's comments earlier. We cannot lose sight of diversifying the perspective of individuals who have the tremendous privilege of asking the questions. Many academics of color, like Dr. Cooper, myself, come from immigrant experiences. I don't come from an immigrant experience. She ultimately did have that refugee experience. But in academia, the historically underrepresented, minoritized populations are born in the US to families that have been here for generations, but cyclically have been denied access to the opportunities for continued education. I arrived at Wayne State in 2020, part of a cluster hire of faculty in the area of health disparities. This was an initiative of the former provost, Keith Whitfield, and our newly established Department of Public Health that's headed by Dr. Patricia Wren. I know she's watching. Shout out, Dr. Wren. We had a successful application for the grad school's Pathways to Faculty postdoc fellowship position. That's an initiative being led by Dean Amanda Bryant-Frederick and Dr. Angelique Outlaw, designed with the explicit goal of increasing the diversity of our faculty. But have you by chance seen the Chronicle's article, Why Faculty of Color Are Leaving Academe? Too many find themselves disenfranchised, exhausted, and isolated. If you're an institution that's fortunate enough to land these faculty, you have to do everything possible to support and retain them, because we're also the people who originally recognized the value of science in addressing health disparities. Because also we have a lot of work to do. We need to prioritize results-driven approaches in our communities, keep the issues of disparities in the forefront of our minds and in the minds of the public. We need to scale up our learnings and continue to build permanent infrastructure. There's a need for proactive action to mitigate those risks. As mentioned in Dr. Cooper's book, there's a need for robust training of employees and contractors around implicit bias. We're unique here in Michigan that it's now required for health practitioners for health licensing, and that's something unusual. Since I've probably gone over time, I honestly wasn't even looking at the clock. My apologies.
No, that's okay. Yeah, that's okay. Why don't we move on? I want to give Rosalind a chance. And Rosalind, I had the opportunity to meet Rosalind just like 4 or 6 weeks ago. I think Michelle Cote, who is a former faculty member, introduced us. And Rosalind, I'm going to try your last name, and I want you to correct it. Jaborjan, I'm going to try, and please correct it. She worked as a research nurse for years in collaboration with multidisciplinary healthcare providers in outpatient clinics at the University of Texas MD Anderson Cancer Center in Houston. She's currently working on her doctorate in nursing at Wayne State University, where she's studying African-American women with breast cancer, which is how we connected, who have undergone mastectomy without reconstruction. She's interested in the potential impact of mastectomy on the emotional, psychosocial, and physical adherence and the effect on quality of life. She also has a trainee fellowship position on the NIH Training T32 grant initiative for maximizing student diversity at Wayne. Lastly, she has done work on oral agents challenges with self-administered medication adherence in clinical trials, and that's published in the Clinical Journal of Oncology Nursing. So, Rosalind, please correct my pronunciation of your last name, and thank you so much for joining.
Thank you so much. So my last name is pronounced Borogan. The G is kind of silent, so it's Borogan. And I want to thank you so much, Dr. Simon, for giving me the opportunity to be part of this panel. So when I saw the title of the book, Why Are Health Disparities Everyone's Problem, I was very excited, knowing that I would be able to relate with the content of the book based on my experiences. So the introduction really inspired me because almost everything discussed in the book seemed to resonate with me. So first, I appreciate the fact that the author of the book is an African like me, and we're both from West Africa, to be precise. Although she's Liberian, while I'm Nigerian, we share similar culture, values, belief systems, and interestingly, like her, I can connect my experiences as a young African girl who grew up knowing both sides of disparities and its impact on people. So Nigeria, as you all know, is highly diversified, in all ramifications. And we have the very rich, we have the poor, and we have the middle class, which is gradually being eradicated anyway. So my family and I, we fell under the middle class. So I experienced disparities, and privileges prior to relocating to the United States of America. So upon my arrival in the States, I was very excited, I could not wait to get into the system. I felt America was a perfect country, with everything one can ever dream of, until I decided to improve myself career-wise and academically. I first noticed disparities when I started nursing school, but I kind of minimized it, I never knew systemic and institutional disparities existed until I got into the system when I graduated from nursing school and became a registered nurse. So I experienced disparities both in school and at work while residing in Houston, Texas, before relocating to Michigan. And like the author, I'm really passionate and about educational and health disparities. And I'm hoping that over time, I'll be able to think bigger and partner with community members, in my research area. And so when I read this book in its entirety, there were so many things that resonated with me. I felt empowered because I realized that disparities in any form is an issue that we cannot ignore, because of the negative impact that it has on our families, the community, the society, and the nation at large. So first, I'm just going to focus on implicit bias. What is implicit bias? Implicit bias is a form of bias that occurs automatically and unintentionally, but nevertheless, whether we like it or not, it affects the judgment, it affects decision, it affects behaviors, So interestingly, most people, including physicians, they have implicit bias, which has poor outcomes. So according to the author, based on their study, many physicians, they perceive Blacks, as to be more negative, than whites on the area of intelligence, education. They believe that they have this likelihood of not adhering to treatment therapy. And you know what? I agree with them in that regard. I remember an incident I had when I was living in Marshall. My son was playing with his cousin's little dog, and he got a dog bite, I had to take him to the emergency at Oakland Hospital. I met this physician and I was really so disappointed, from my interaction with him. So from his non-verbals, I felt he had already stereotyped me, His assumption could be, oh, she has less education, low income, she might not even ask any questions, during the visit. So the physician came in and he was not friendly at all. It was focused on the medical issues that brought us there, He spoke for about 2 minutes and decided to write a script, for antibiotics. And he was on his way out when I politely called him back, stating that I had some concerns, which has not been addressed. I told him I was concerned about my son's tetanus shot status, which was expiring that month, So he stood by the door and when I started speaking, he had to come back into the room. He took a seat and we spoke for close to 10 minutes. Before he left, so he virtually wanted to know everything about me when he realized that I was a doctoral student, at West State University. He told me he was very impressed that I took time to research and came up with relevant questions. So I agree with the author of that book, when they talked about white physicians, they said they often discuss medical topics with Black patients, while they have a more balanced content of medical and social topics when talking to the white, counterparts. And I did find out that based on that experience that I had, it's true. And again, I'll quickly share one experience that I had just this month, I went to the doctor's office with my husband, who was scheduled to have a minor surgery, endoscopy to be precise. And we were sitting in the waiting room, just waiting. And my husband, of course, he had a white physician. She was good, very good in communicating with her patients. So I saw her come into the waiting room a couple of times. She will update members of the family members about the progress of their loved ones, And in the process, I observed her discuss social issues, besides updates on patients' well-being. So as a nurse, I liked her, I felt she was practicing holistic nursing, which we all do, And I could see everyone laughing, they were sharing jokes, I was patiently looking forward to having a good conversation with her. But unfortunately, when it came to my turn, she came to update me about my husband, it wasn't the same, She dominated the discussion. It was purely medically oriented, our discussion, So I agree with the author that physicians are verbally dominant with patients, but even more so with Black patients than with white patients. I think they said about 73%, more dominating compared to 50% with whites. So it was interesting to learn that the author, discussed the fact that she took the race implicit association test and had a slight implicit preference for whites over Blacks, even though she had grown up in Africa and felt very proud of her African heritage, She said she began to pay closer attention to her own behavior with patients, close social characteristics and that were kind of different from us. She was really paying attention. So I want to take a pause here and say that if every one of us, if we decide to be truthful, it will sober us, just like the author said, It will sober us to realize that even with the best intentions, we may all be guilty of engaging in biased behavior, with people from another race. So my take home from the reading of this book is overcoming bias. How do we overcome implicit bias? So I completely agree with the author that our understanding of what implicit bias means, is the first step to reducing it. Although, like the author said, implicit biases, they are difficult to change, but we can change the experiences. So they talked about a couple, which I'll just run through so I can keep to time. So they did talk about stereotype. That's number one. We need to be deliberate when it comes to stereotyping. We must recognize that the response you are receiving at every point in time it should be your reality. You don't need to stereotype. Then the other thing they talked about was counter stereotyping imaging, and one can achieve this by spending time thinking about people that don't stereotype. So the more people that don't stereotype, the more you'd not want to do that. And the third thing they talked about is individuation. That was very interesting. You treat people the way you want people to treat you. You just go ahead and you don't categorize people by race, and just say because this person is like this, this is how this person is going to react. That is not good, So we need to, at every point in time, be able to put ourselves in the situation of people. So in summary, the authors truthfully said that implicit bias cannot be changed, However, it can be interrupted, And so we need to, I love the fact that she came up with a checklist, That's beautiful. So if most of us can do that, it can help a lot, because this implicit bias is not deliberate, we just don't know we have it, but we have to be specific, we have to be intentional. That's the word I was looking for. We have to be intentional. So the first thing she talked about, the checklist, she talked about respect, that you need to respect people as human beings, whether you agree with them or you do not agree with them, you need to respect them. Then the next thing is empathy. You need to empathize, you need to be able to put yourself in another person's position. If you're able to do that, it goes a long way. Then you need to listen. You need to talk less and listen more. Then you need to ask, ask yourself what assumptions you're making about this person. Is it based on fact? Or is it based on, stereotype? You need to talk with people about their personal life, get to know people as individuals. You need to engage people. When it comes to problem solving, you need to look at their opinions. So I'm going to go ahead and end my comment by answering the question, why are health disparities everyone's problem? I think health disparities are everyone's problem, or should be everyone's problem, because the outcome is negative. And it has a multiplier effect that negatively affects everyone, either directly or indirectly. Thank you.
Thank you so much. Thank you so much. Very, very powerful. And I think actually when I met you, you explained that the G is not pronounced. I just forgot. So thank you so much for correcting me. And eventually I get it. Not too long. So this is a time for questions. Yes. I'm going to look in the chat, and I want to make sure I don't miss anybody's questions. I see an amen there, so that's wonderful. So I'm going to throw out something and give myself a minute to read through a couple things from chat, and also I think it's time for the panelists to react to each other. We have a good 15 minutes or so. So, one question, yes, implicit bias, and I know we have wonderful researchers, and I've been part of these studies here and I've been not only as a researcher, but I've also been a participant in the study. So I've been filmed talking to my patients of color and my white patients and analyzed. And we've done such great work here. I'm wondering, what, if anything, can we, or maybe we are doing here for example, our fellows? So I just came off of rounding a couple times in the last month, and it's not uncommon for me to hear somebody, instruction to a patient, and then a couple minutes later, I'll ask the patient, well, what do you understand from this? And they would completely not understand anything. And I think it's a communication issue, but I also wonder if it's a disparity issue, because of course, a lot of the patients we're talking to are Black patients. And is there a disparity issue because we're not properly communicating? Any comments about that from the panel?
I'm sorry, can you reframe that? So, or rephrase that? You're saying that, yeah, I'm not sure. if
Yeah,
I'm-
I'm wondering, okay, what I'm saying is what can or should we be doing for our trainees here to combat implicit bias? You know, we have all this great research and we have great investigators looking into this. And then we have 6 or 7 new oncology fellows every year. And I experience this with my fellows on the ground that I say the patients don't understand us, not to say 100%. Of course, they're very good doctors and they're trying their best, but what, if anything, can we be doing to help combat implicit bias?
I'm hearing 2 different things. I would love to hear, the panelists comment on it, because I'm hearing you talk about a communication issue, that patients are not understanding what you're communicating with them, which sounds to me like a health literacy or a cancer literacy issue. Yeah. Versus implicit bias. That's a different topic. So I don't know if other folks want to comment on that. So, in terms of the cancer literacy issue, that is something that can be, first of all, there are techniques that people talk about in terms of that issue, like teach back, or strategies like that. And that, we work with the same researchers here at Karmanos about strategies around communication. So, that's certainly, there are strategies that exist that maybe we need to be integrating into our curriculum so that we make sure that we are asking, that our patients understand us. I think to the extent that our patients aren't willing to ask us questions and clarify, is a question around relationship building. And that's where implicit bias also perhaps might be connected, right? What is happening that is impeding our building relationships and with our patients, right? Or with your patients. So I'll let I'll start there and let the other panelists complete.
Yeah, I think building on that, just the importance of the medical home to be able to build those relationships, and the overwhelmingly small percent of minority patients who have a reliable patient home, medical home, to have those continued experience and continuances of care, and can be incredibly important in intervention work. That's my only add-on.
Just to piggyback into what the 2 panelists just talked about. So I think the training, it's very important when it comes to implicit bias. So people need to know about other people's culture, their belief, the way they react to things. I'll give a typical example, like African Americans, and African Americans, when it comes to blood pressure issues, you find out that most of us, we think is stress oriented, which could be, stress induced, but at the same time, there's a way they want to believe in it. They don't want to believe, they don't want to do medication and things like that. They want to go spiritual about it. They'll feel if they rest, like, oh, if I feel good, it means my blood pressure is not high, but that's not true, So one may want to address it medically. So here comes this physician that is white, that is talking to a Black person that has high blood pressure. How do you relate to them? Can they trust you? Is there transparency? Are you reaching out to these people? Are you, trying to make them understand why they should focus on their, take their medication, the impact, So those are disparities. So most times they don't go to that level. They just assume, oh, this person is not going to be compliant, So you don't know where that person is coming from, but then you stereotyping right there, So they need to, there's a lot of training that needs to be done for that's a disparity, to be reduced, We just need to work on that as healthcare professionals.
Okay, great. I want to maybe quickly paraphrase a comment Bill Winkler made to everybody. I don't know if it's specifically a question, but pointing out that there is a program at Wayne State School of Medicine called the Standardized Patient Program, which focuses on training these young students in effective communicating with their patients. It's run by Joshua Collins, and just pointing that out to everybody. Does anybody have any comments on that program or know anything about that? Trisha or Haley?
Yeah, I don't know about that specific curriculum. I do want to kind of build upon it, because I agree. I think I think it's so important that, we know we have implicit bias training in our medical school already here, now it's being mandated by the state, but I also want to kind of raise a concern that I have, and I don't have an answer to this totally, and it's something I'm investigating, maybe somebody else knows more about, that, implicit bias training is one thing to gain this awareness about, how we perceive people, communication training is important. I don't know if that's the same as kind of more anti-racism or anti-oppression training, that perhaps focuses on kind of more on power, privilege, microaggressions, and so on. So that's a question and something I think a lot about. It's one thing to have implicit bias training. It's one thing to be aware. It's one thing to even kind of say the right words, but we know through the IAT, the implicit attitudes test, it's not implicit, but the IAT attitudes test that looks at implicit bias, that, there may be other, even though we may have an awareness, that is not necessarily enough to shift, those attitudes. It's not necessarily enough to shift behavior. So I'm always curious and thinking about, what is the content of these trainings and, how broad are the issues that these trainings address? That's just kind of my comment or just a thought that I have and a concern.
And any comments on that? And maybe that's one of the goals of, I mean, this isn't really anti-racism training, but I guess I have this hypothesis that reading books about disparities and racism in medicine, the legacy of racism in medicine, at least it's going to teach us this there. Teach the people that need to know that, and actually, as you pointed out earlier, this, and the Black community knows it, and maybe it's really more for my community. There is a comment here, we have to stop calling them clients and get back to remembering that they are patients and respect them. And any comments about that comment? I guess maybe or Haley, were you going to say something?
No,
Okay.
no. I mean, I know something that is driven by discipline. So, and in some contexts, it's thought to be more respectful to call them clients versus patients. So I know that varies. So I don't know. I think, but in terms of regardless of what, I don't know how important it is what we call people versus, again, how we treat them. Sometimes we might get too caught up in labels and so on, and that takes us away from actual behavior and impact.
Right. Maybe it's really more in psychological services that people are called clients. I like to think of, well, we're all patients. That's why I have this idea of meeting on the bridge. We're all patients at some point, or most of us are going to become a patient at some point. And so it's just so happens I'm sitting in one chair at that particular moment, but I'm very likely to be in another chair at a different time facing somebody and dealing with me. It's kind of interesting with the reaction to what Rosalind was saying. We had Dr. Tweedy speaking about his book, Black Men in a White Coat, and he made the point saying that whenever he goes to a doctor, he makes the point of dressing up so that they know he's a health professional, and maybe that they're not just reacting to his Black skin, but they know he's a professional. And so I was resonating about what Rosalind said about being treated well by a white doctor. That again, we shouldn't necessarily just look at how people are dressed, but we should look at who they are and what they're saying and what their background is. Let me see if there's comment here. To take greater advantage of organizations that are offering assistance in mentoring patients. Hang on. Okay, so now I lost that. Take greater advantage of organizations that are offering assistance in mentoring patients by patients who have the same disease, example, cancer, leukemia, lymphoma, to improve communication. I think that always helps. Our volunteer sort of setup has been shut down, for a large part because of COVID, but that's something that a lot of people that I work with, my patients, are interested in talking to other patients, to help in understanding Let's see, we're looking for questions here. Let's see if there's anything else. Oh, in the question and answer. Okay, there's a question and answer. Okay, this is from Patricia Wren. I've been struck by two key points: supporting scholars of color and centering public health work in community organizations. Can the panel link those 2 points and talk about how universities can lift community partners and ensure those leaders don't burn out and leave this vital work? Any thoughts?
I can start. So I think that's some of the work that we're trying to explicitly describe that we're doing with HEAL, and that I mean, if you think of, I know a number of our public health students are interested in working in nonprofit organizations, for example, and nonprofits are tasked with so many different duties with a really tiny staff. And then you add the pandemic pivot that happened for so many organizations. And I think wherever possible, where we have the opportunities to do some of the work on behalf of our organizations, to bring our expertise of analyzing the evidence and summarizing it and translating it and disseminating it out for that uptake into practice. I think those are really important. We don't focus on that translation and dissemination work enough on the academic side, and our community partners could really benefit from us lifting that up. And then on the other side, lifting up their work, so helping it to be evidence-based, helping them to measure their impact, and then disseminating their work out into other audiences as well.
Yeah, I would totally agree with all those statements. I do think it's important to think about. So, in our work here at the Cancer Center, our Office of Cancer Health Equity and Community Engagement, we work with a lot of community stakeholder groups, organizations on a grassroots and grass tops level. One of the things I will say, though, in terms of universities and their role, because, more and more, especially as we have a health equity focus, there's an increasing interest in engaging communities in this work. But there's a problem, right? Because universities aren't really set up to do this work. And there are a lot of barriers, structural barriers at the university level that I know people like, Dr. Tricia and myself, we're trying to make headway in terms of making that work easier. If we want to work with communities, and let me say that I know as someone who writes grants and tries to fund this work, it's increasing. Our funding agencies are paying attention to the kind of the quality of community engagement of scholars who are applying for funding too. And we have tremendous issues in terms of paying our community partners. I strongly believe that when we bring community partners into our work, we need to compensate them for their time. We have a lot of issues about, even if we want to, ideally, we're going out into communities and working with them, but to the extent that we are asking them to come to our center, we have to think about parking. That's really, and transportation, those can be barriers to the work. I think about, when we want to bring our folks into our science and having them complete, get certified by the IRB, the Institutional Review Board, so they can actually really be partners in the work. There are barriers at that level. So that's something I think we really have to pay attention to, is sort of how are our universities creating barriers or facilitating our meaningful work with community stakeholders.
That's great. Thank you. And Rosalind, I want to give you a chance to respond. And we're almost at the end of the hour, so maybe in the next 30 seconds or so. Rosalind, any comments on Dr. Wren's?
I don't have comments on that.
Okay.
No.
Let's see. Okay. So generally at this point it's 4:59, and I don't like to keep people past 5. Danny, do you have some sort of closing statements?
I sure do.
And I'd like to thank everybody as well. Please certainly thank the participants, the questions, and the panelists. Go ahead, Danny.
All right. Well, thank you everyone for coming, joining the webinar. Thank you so much to our panelists. It always seems like we have never enough time to cover all the issues that are brought up. I want to remind people 2 housekeeping options. As soon as you leave the webinar today, you'll be prompted with a survey to see what's working, what's not working with the format, with the book selections, with emails, all kinds of things. and also with how you're engaging with the material. We're keenly interested in how you're doing that on a day-to-day basis or after you leave the book club with us. I also want you to bookmark or put on your calendars. Our next book club meeting will be Thursday, March 30th. The book is still yet to be decided, but in January, after the holidays, I will be sending out an email, and that's where we will pick our selection for the quarter, something that we've been doing for a while, and it seems to be really nice, and people like to pick the book. So I want to give everyone a chance to do that. At the end of the survey, you have a chance to submit any books you would like us to follow up on or read, and those are the ones that get pulled together and get put out for the wider reader audience to choose from. So keep your eyes out for that email to be coming after the new year. So on behalf of everyone here, thank you all so much for joining us, and have a great day, have a great holiday, and have a good happy new year.
Bye.
Thank you, everyone.
Thank you, everyone.
Thank you. Bye.